Among all metabolic disease, ricket or osteomalacia is very important for our undergraduate student and also for post graduation student. As per as the disease is concerned, that is a disease which affect the end condyle ossification, and as we all know, the ricket is due to vitamin D deficiency. Not always. The ricket can cause multiple can cause due to multiple problem, or it can the treatment is also varies as per the disease is concerned. So I think a clear concept of ricket is needed to encounter all the questions as well as in our practical um, purpose. And I feel that the treatment part of this disease is very confusing. Now start from the clinical features and the pathogenesis. As we all know, that pediatric bone has a special type of structure at the end of this bone is called physis. Now normal physis has 5 zones, and among them uh, the the zone of ossification is close to the metaphyseal region, and all the physeal layer is highly proliferating, and zone of hypertrophy is highly vascular. Now in the ricket, what happened, the due to increase of zone of proliferation due to vascularity, the enlargement of the metaphyseal area, and it can evade the adjacent zone of degeneration. Now uh, due to newly formed tissue called as osteoid, which is excessively deposit and being soft, it gives way with a pressure, causing bulging or deformity of the metaphyseal area of the long bone, and this is responsible for flaring of the long bone end. Okay, due to vitamin D metabolism problem or any type of region, the this zone of degeneration will hamper, and which can cause this type of flaring. Now in case of active rickets, along with the flaring there will be also a cupping. Cupping means uh, n- in growth will be restricted in this center. This is called cupping, and along with some splaying means the increase the length, wide width of this wrist or width of the metaphysis. So three things is occur: cupping, splaying, and fraying. Now due to softening of the whole bone, there is a chance of bowing when patient bowing of the weight bearing bone when patient bearing the weight at the uh, end of 1 to 2 years. Now when that is treated with vitamin D, then there will be a zone of preparatory calcification layer where the calcium will deposit, and that must be seen after vitamin D injection or oral treatment. Okay. Now clinical feature of ricket is keniotaps. Keniotaps found in a is like a ping pong ball, or and it's very weakening of the alvarium, and there is a weakening of the ribs. As a result, there will be enlargement of the costochondral junction that gives appears to a bead like structure. This is called ricketic rosary, and in associated with high rise of alkaline phosphatase enzyme in the ricket. And if this ricketic rosary is painful, it is found in scurvy also. but in case of ricket, that will be only palpatory finding, but will not so much tender. And advanced ricket, we can found the bossing of the skull or polyversion of the cartilage of the occipital and parietal eminence makes the skull looks like a box. And enlargement of the head circumference and delayed closure of the anterior internally, which remains widely open, and delayed eruption of the primary denture, and possible due to enamel hypoplasia. Now the deformity we continue in the chest wall. The sternum will deform, that can cause portosio of the thoracic cage is also called Pigeon chest. And also there is a groove. There is a groove over this lower end of the thoracic cage. This is called Harrison sulcus. Why this Harrison sulcus occur? Because due to insertion of the diaphragm or origin of the diaphragm in the lower one part of the inner part of the thoracic cage, due to repeated traction of this or repeated contraction of the diaphragm, the weak bone gets invade along the line of the diaphragm insertion. So this is called Harrison group or Harrison sulcus. Okay. Now in the advanced stage, the liver and spleen become palpable because the weakening of the rectus muscle. So it also present a pot belly appearance or punt belly like syndrome. But the punt belly is defined congenital anomaly, which is absence of rectus muscle. But here there will be protrusion of the abdomen, and also due to pelvic inlet narrowing, that will exaggerated. And regarding the extremity, and as child try to avoid bear, there will be the softening, and due to softening of the bone, there will be bowing of the long bone, and as well as there will be genu valgum or genu verum deformity. Okay. Now chance of fracture is also common in this ricket, like Toras fracture, gastric fracture, and the metaphyseal region will be widening, and most commonly we can found the wrist widening, and also ankle can get the depth. In the old cases, and in the advanced stage, we also found there will be kyphosis. And along with this defect of the physeal plate growth, the dwarfism also occur. So it is also called a ricketic dwarfism, and the muscle power will be very less and lacks and loosen lacks ligament. So it also delayed the locomotor milestone due to weak muscle. Now before going in details for ricket, just remember or just recapitulate our first year knowledge, physiology knowledge, like due to ultraviolet ray, special type frequency ultraviolet ray, the skin 7 dihydrocortisol, it turn into cholecalciferol, then for with that dietary intake, and it will convert 25 dihydrovitamin in the liver, then the 125 D3 form, and this is the biologically active form, and that will help to maintain the calcium balance in the body. So just keep in mind, I just recapitulate why, because one hydroxylase will be added in the kidney, but 25 hydroxylation is occurring in the liver. So that is very important. We have to understand the different type of ricket. Now along with this there is a special type of biological feedback in our body due to parathyroid hormone. Now, if there is low serum level in our body, that will sense the receptor which is present in the parathyroid gland and which increase the parathyroid hormone. Now, normally the parathyroid hormone acts in the intestine cell, which can increase the absorption of the calcium. And in the kidney, how it act? It will act the 1 hydroxylation. So active form of vitamin D3 will be increased, and it also help for calcium reabsorption in the renal tubule. Okay, and bone, there is a effect of the parathyroid hormone which can increase the calcium release in the circulation, because bone is the storage for the calcium in our body. Now, when the low serum calcium occur, that will activate the parathyroid gland, that will increase the parathyroid, and due to action that will act by intestine or kidney and bone, both all will increase the absorption of the calcium, the active form of the vitamin D3 and calcium absorption, and increase calcium level in the circulation. So as a total, the calcium will increase. Then at the when the level of the calcium will be adequate, then again that will be do a negative feedback over there, and again the parathyroid level will decrease. So this is a biological feedback, that is normal hemostasis maintained in our body. But when this will be hampered by any type of disease, so that will hamper the all hemostasis of the calcium and vitamin D metabolism. Now, as a orthopedic surgeon, truly speaking, the pathogenesis of all type of vitamin D deficiency or ricket, to understand and to properly diagnose or to the going to the final treatment is very difficult. So I think, as per our knowledge is concerned, we should take help of pediatrician or medicine. Otherwise, we are not doing proper justice to our patient. Now, but as a orthopedic surgeon, we have to exclude some or we have a proper approach to the patient. Like, we have to know maximum cases is nutritional. If it is not nutritional, then it is non-nutritional. Then non-nutrition can be cause GI cause, or any other cause like renal cause. Now, if there is no problem in GI, then we have to think of renal. Now, if patient is a renal failure, if this patient is a chronic kidney disease, then we can think about renal osteodystrophy. This is one type of ricket. So you have to take care of that. If there will be no renal problem, then we have to think about renal tubular acidosis or Fanconi syndrome or familial hypophosphatemia ricket. But if there will be no clue, then the problem lie behind the last part, which is end stage end organ resistant, means vitamin D resistant ricket. Means the vitamin D will not properly form or not properly act to the this intestine or kidney or bone. So this is called vitamin D resistant or receptor problem. Or there will be some oncological causes that can cause the damage of or the disarray of this biological feedback and can cause bony defect. This is called oncological decay. Now we have to go through all the types. Is when there is related with calcium or related with phosphate. Now calcium related is vitamin D deficiency or resistant. And one is dietary, one is malabsorption, lack of sunlight exposure, defect in the 25 hydroxylase in like any liver disease or any medication due to long term phenytoin, or failure of the 1 hydroxylation which is found and 1 alpha hydroxylase decrease in the kidney. So vitamin D resistant ricket type 1. But another problem of vitamin D, end organ resistant. So receptor is a defect. So it is also called vitamin D resistant type 2. Now I already told about renal osteodystrophy and the calcium deficiency. Now renal there will but as a all total, if there we can get any clue, then we have to think about isolated phosphate loss, a genetic type of mutation where is all can be occur X-linked, it can be autosomal recessive, it can be autosomal dominant, and last but not the least is hypophosphatemic ricket with hypercalciuria. It is special type of problem where genu valgum will present in the pediatric age group just at the puberty. That patient present with this type of problem, hypophosphatemic ricket. So this is a special entity which is very important topic for medicine and pediatrics, but you have to know that. That's all. And a special type of syndrome is called renal Fanconi syndrome. Is also is a cause of renal vitamin D deficiency. And dietary phosphate deficiency is also occur can in indicate or phosphate malabsorption. So after that you have to go for the treatment. Now there are multiple type of treatment guideline, but as a whole, if you can understand which is vitamin D dependent ricket, we can give oral vitamin D dose 1500 to 5000 international unit per day for 6 to 8 weeks, or we can give it in a stock therapy, or we can give it 6 lakhs international unit IM injection, or we can give it orally also, but it in a single dose is also called Strauss regimen. But sometimes the Strauss regimen may cause toxicity to the child, or very young age cannot tolerate this type of Strauss therapy. Then we can go for this treatment. As per weight is concerned, we can use 1500 to 5000 up to 6 to 8 weeks of duration. But this dose must be take help of the pediatrician, otherwise that can cause hypervitaminasis problem and multiple problem also. And after 2 to 3 weeks of this treatment, we have to go for radiological investigation. Pre-operative radiology is there is a spraying and cupping. After the treatment, the repairing of these physis can also occur. Okay, so this is and the zone of pituitary calcification or sclerosis will be found. So and this is the treatment guideline, and this is X-ray is the treatment tool. Along with alkaline phosphatase level will decrease after the healing of the bone. And last but not the least, there is a special type of bone problem found in the vitamin C deficiency also. It is not related with ricket. Just for information, I put this slide. Just know due to collagen deficiency or collagen yield development, there will be a chance of subperiosteal hematoma or subperiosteal hemorrhage. There is chance. After that, there will be a zone of rarefication in the pituitary zone of calcification. This is also called scorbutic zone or Trumfield zone. Okay, and there is a chance of dense osteosclerosis or dense zone of pituitary calcification just towards the epiphysis. This is also called white line of Frankel. White line of Frankel. Okay, and in the physis, in the epiphysis, there will be a good white zone. See, this is the white zone. This is called Wimberger sign or ring epiphysis sign. Burger sign. And in the lateral end, where the zone of preparatory calcification occur, in the lateral end there will be spar. Okay, this is the spar. This is called Pelkane spar. So as a total, we just give a revision. Sub periosteal hemorrhage is the most common. Then this radiolucent zone is called scorbutic zone. Then the zone of preparatory calcification is huge. This is called zone dense zone of preparatory calcification, or zone white line of the Frankel. It's called white line of the Frankel. Then epiphyseal line, and then Pelkane spar. So I think I can cover the metaphyseal and the epiphysis along with the all type of deformity found in the metabolic disease in the pediatric age group.